So this was a trial comparing TAVI with surgery, SAVR, specifically in not only low-risk patients, but also really young patients. We were targeting truly young patients, so there was also, they had to be 75 years or younger. In reality, this meant they were between 60 and 75. And we allowed also patients in with a bicuspid aortic valve stenosis. So that was the kind of the novelty about this, because there were a couple of low-risk trials already available, randomized controlled trials, but these were typically all mainly still including older patients and were absolutely excluding bicuspid patients. Typically, if it started out with really elderly patients, and if they present with severe aortic stenosis, they're typically by definition almost tricuspid. So we find much more bicuspid aortic stenosis in the much younger patients. Then it goes exponentially up. As soon as you go below 65 years, it goes really that's the majority of patients has a bicuspid. So that's why, because TAVI also started out with the older patients, it was not very prevalent. It was maybe only representing 3-4% of your patient population. So it's normal that these trials kind of exclude these higher risk anatomical patients and focus on tricuspid. But if you want to really be honest and go check and compare TAVI versus surgery in real younger patients where bicuspid aortic stenosis is more prevalent, then you should also allow to include them. So maybe first overall, I would say there was some clinical equipoise between TAVI and surgery for the composite endpoint, which was a composite of death, stroke, or rehospitalization. There was no major differences, 10% in TAVI, 7% in surgery. But it's true what you say. There were some discrepancies between the findings in tricuspid. In these young tricuspid, low-risk patients, I would say the clinical outcomes were really on par. I mean, really, like it was 1-to-1. Only that there was 3% of PVL in the TAVI arm versus nothing in 0 in the surgical arm. This was different indeed in the bicuspid arm, where we saw more favorable outcomes with surgery as compared to TAVI. There were more PVL. We had 9% of PVL, moderate or greater PVL in this TAVI arm. Again, this was an unselected bicuspid group. We didn't want to be too selective, so that's an explanation for that. And also we saw a signal of more stroke in these bicuspid patients treated with TAVI. Look, we have to be humble and modest about this study too. We had 100 bicuspid patients in, which was nice in the first study, but I think it's especially these results are a cry or a call for more data in this field. We have to really consider doing, if we want to investigate this, then we have to do it properly in a powered enough study, comparing TAVI and surgery in a bicuspid population. And then, of course, the lessons learned could be that we have to be more selective maybe in which phenotypes of bicuspid aortic stenosis do we accept or not, or are we going to offer this? And that's something we have to learn still. We wanted to be very open in this trial to have this signal and to see what's happening, but we learned that we have to be more selective, and maybe indeed cerebral embolic protection. If we saw some early periprocedural strokes in these, so it makes kind of sense if you go into these TAVI in young bicuspid patients. Why not consider this? We didn't have a real expectation. Of course, we based it a bit on the partners tree. That's also how the study sample size was calculated, yes. But it showed out that it's a very different population still. Our patients were much younger, or at least they were not much younger, but they were much more robust patients with much lower comorbidity levels. And then we had these bicuspid patients. And so I think that the key take-home message for me was that you have an overall procedural risk, and you have an AVR, the act of replacing the valve risk. And in the older patients, even if he has a bicuspid patient, then the procedural risk is probably still higher with surgery than with TAVI, which is truly minimally invasive. And then probably you can proceed with your TAVI in your older bicuspid patient. But as soon as you go past a certain robustness or age, or it's maybe not age, but just fitness and surgical risk, if it's really, really low, as in our trial, 1.1 STS score, which is extremely low, then maybe the surgical risk is so low, the overall interventional risk of the surgery is so low, then in fact, indeed, if you intervene for a surgeon excising a bicuspid or tricuspid valve, it doesn't make any difference. For us as a TAVI operator, if we go in with a TAVI and a bicuspid valve, it's more interventional, more invasive you could almost say, than in a nice symmetrical tricuspid valve. So that's also something we kind of learned or could learn from it.